Assalamu alaikum. Good day, everyone. Welcome to our webinar. My name is Ala Al Umari. I'm a patient safety specialist, and I will be serving you today as your moderator. And before I started, I will let you know that you can post your question in the Q&A panel at any time during the lecture and will be answered at the end of the lecture. You will be hearing today from our presenter, Dr. Yusuf Al-Aoumi. He will be speaking to us on medication safety event reporting and learning system. Dr. Al-Aoumi, a former head of General Administration of Pharmaceutical Care Administration, former head of National Drug Information Center, former head of Research and Development Department and Pharmaceutical Care Administration at MOH, Saudi Arabia. Dr. Al-Aoumi is a product of King Saud University, confirmed with a degree of Bachelor of Pharmaceutical Science in 1992. Then he has his master's degree in clinical pharmacy in 1998. He is an affiliated clinical instructor of Purdue University in the USA. He is adjunct assistant professor at King Saud bin Abdulaziz University College of Pharmacy. Dr. Al-Aoumi was a member of Pharmacy Board at Saudi Commission for Health Specialists and head of Pharmacy Accreditation Committee. Also, Dr. Al-Aoumi, he was a team member of establishing a first pharmacy residency program in Saudi Arabia. In 2005, he obtained board certification of pharmacotherapy specialist. And also in 2008, he obtained his diploma in business administration from American University in Egypt. Also, he has a board certification of nutrition support pharmacy in 2009. Currently, he is editorial board member of various national and international biomedical journals. That include Drug Therapy Perspective, Hospital Pharmacy, and International Journal of Pharmacology and Clinical Science. Also, he had several researches in clinical pharmacy and pharmacy practice published in ACCB, ISPOR conference, and various journals. Welcome now to our speaker, Dr. Al-Aoumi. If you may, please, you can start.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. Thank you, Mr. Chairman. Today, you are welcome today to discuss something about our experiences and the practice about medication errors, documentation system, and impact of as a learning system, and also for any designing or new designing program as impact and outcome of medication error, or let's call it medication safety, because medication error is a part of very broad program. We call it medication safety. I don't have anything to disclosure. I think by end of this lecture, you will know some statistical data about medication error in our area or around the area for all Middle East. And also you have to be familiar with the medication error reporting system as general experiences in Saudi. And also we'll discuss about the medication error learning system, what's the basic element of medication safety or medication error education and training. Then we'll discuss broad about outcome of impact and clinical outcome as a learning system of the medication safety implementation in Saudi. This is a systematic review of literature, and to discuss the medication error, they found as error prescribing represents starting from 7 to 90%, they have an error, while the administration, it's almost the same thing, from 9% to 80%. Most of the prescription, they have a medication error or rate, was specifically emphasizing the incorrect dose and wrong frequency and wrong strength, which is, this is the list of the country, which are huge numbers, prescription, more than almost 100,000 prescription with a general Middle East country, including different countries, Saudi and Bahrain and Egypt. And all these, they're including each one of them, they have specific dosing number of prescription and dosing error as a percentage. Then a study for systematic review of the safety of medication, and they included almost 54 study, including criteria. They found the prescribing error reached to the up to, I can say, 50% or 56%. And maybe they found the adverse drug reaction or adverse drug event represent almost from 8 to 16% per each 100 admission. And if we discuss about drug-related mortality and morbidity in the state, we found that most of people admitted to the hospital due to drug-related morbidity and morbidity. I mean it, drug-related mortality and morbidity, I mean the medication error or adverse drug reaction or non-compliance, overdose, underdose, without medication, as American Society of Health Pharmacists classification. They found in the state the economic burden of the drug-related mortality and morbidity reached to the $177 billion, which increase reached to the 103%. This is for 2000. Before, I think, a couple of years, another report coming in the state, they reach almost $300 billion as economic burden impact of drug-related mortality and morbidity, and medication error was among of them. Local study in Saudi and including healthcare professional, and we calculated and estimated the drug-related problem in Saudi, which is the average almost reach $122 billion annually. And the most high percentage of the drug-related mortality and morbidity was non-compliance or adverse drug reaction, while the non-compliance represents almost 30% of the cost, with the adverse drug reaction represent 25%. If you also another third, I can say the third problem can represent also the medication without medication or medication errors. That's including, they give you some picture about drug-related mortality and morbidity, including medication error and adverse drug action. We established a program before almost, I can say, more than 10 years now. We have set up a national medication and reporting system, and we have designed a form. If you want to make a form, I'm highly suggested to make a form and generalize it for all the hospital and all healthcare facilities, and also all the pharmacies, including healthcare facility, and also including community pharmacy. You need to identify what's the medication errors, and also you need to identify what's the risk, what's the definition of near miss, and what's the category as with the different classification of category as a outcome of errors. But you need to specify. This is the form that we use it since a long time, before 10 years, and now we converted to the electronic documentation. Most of the feature of the manual documentation resemble to the electronic form. You need to identify what's the date of error, who's committing error, which type of error, as type of prescribing or administration or dispensing of medication or transcribing or administration or even monitoring. You need to identify what's the outcome of error, what's the impact after the error has occurred, what's the impact to the patient. Did the error reach the patient? Did the error reach the patient, but there is no harmful? If the patient maybe gets harmful and visit the emergency, maybe get more harmful and admitted to the hospital, sometimes it will be sentinel event and that means maybe the patient admitted to the hospital or admitted to ICU, or they have a permanent disability of the impacts of medication error. You need to also to identify what's the causes of the error, what's the reason behind that. All these documentation, you can make it as a manually, you can use it as by electronic system, anything, but you need try to simplify, try to educate your people about how to document, try to make it as a generalized form and distributed to around your area. This is why the famous category of the medication error. You need to identify the outcome of the error. What's the meaning of category A? It's high risk, or the B, near miss, C, error occurred, admitted to the hospital, or not reached the patient, or something accordingly. You need to calculate, you need to identify what's the error, it's okay, and why, and fill this form. And also, once you're filling this form, you need to set up program. We call it here medication safety. It's not only emphasizing of medication error. A medication error is a part of it and represent high percentage of the program, but you need to make it very broad, because some element related to the error come from another reason. For example, if you have a patient or if you have a medication dispensed to the patient and the quality of the drug is not good, maybe harm to the patient. This can be error. You need to set up medication safety program. This was documented and published as a brief story about medication safety program at Ministry of Health at that time. This is the article published before almost 8 years back. We put some medication safety program committee. This is central committee. Then the central committee, we divided to the regional committee, and the regional committee will also subdivided to the local committee for each healthcare institution. And also we set up medication error documentation as a reporting system. If you have any healthcare staff, a pharmacist, physician, and nursing, he has to fill the form and send it to the pharmacy. The pharmacy, they collect all the form and make it as Excel sheet at that time, then send it to the regional committee. They will discuss it. This is after discussion, after put all the impact and make local analysis, and the pharmacist at the local level and with the healthcare facility, once he collected all the medication error, he has to analyze it, he had to present it to P&T committee, and he has to present it to the all healthcare staff to get them back and to prevent in the future of the medication errors. And also we have unified advisory action at that time. Now Saudi FDA take care of it. And also we have a form with the Saudi FDA drug quality reporting system that if you have any comment or any incidents of the quality of the drug, bad packaging, bad coloring, bad storage, this one can report it to the Saudi FDA. And also at that time, we designed basic medication course. We designed a course, and they are requested from all healthcare staff, our representative medication safety committee, to give this course for all new staff and for all staff, and also and issue some certification of medication safety certificate that should be renewal every 2 years. And this is very important to be compliant with all the medication safety program. And also, that we discussed, medication safety officer should be open. Then after that, we start with some element of the medication safety program, like assessment of medication safety in the hospital, and assessment of medication safety in the program in the primary care. Then after that, we put some medication error guideline, medication safety guideline, like pain management or drug evaluation, whatever. But this is the basic element of the medication safety program you have to start with. And also for medication safety, this is the content of medication safety course of the medication error. You need to discuss in the lecture, for e-lecture delivered to the healthcare providers, as what's the discussed about national patient safety goal, and also you need to describe and explain to them what's the medication use system and drug distribution system as a local and for your healthcare professor, healthcare facilities. And also you need to educate and teach your people about medication error, how to report, when to report, what's the chain of the reporting system, medication error, and also for adverse reaction reporting system, drug quality. You need to educate them about handling of hazardous medication if you have any chemotherapy medication. And also you need to tell them about multi-dose medication stability upward in the ward. If you have a nursing attendees, you need to put a system for that and educated once the nurse open any parenteral medication, you need to tell them what's the stability or oral medication, for how long to stay without any expiration. You need to write at what time they open it, at what time they expire the drug. Discuss about things looks like and sound alike medication, because a lot of reason behind of that. You need to discuss about something a high alert medication, which type of medication do you have, like parenteral nutrition, anticoagulation, anti-diabetic medication. The list we can determine by, it's what's determined by ISMB, an institution safe medication practice in the state. And also you need to discuss what the approved and non-approved abbreviation. This is very important. As a rule of thumb, here in Saudi, we prevent all abbreviation. There is no approved and non-approved. Most of the time, we have written down as a full term. And also discuss about intrathecal and epidural medication, how to administer. This is very important, and this is one of the big mistake. If it's okay, maybe can had a permanent disability of the patient. You need to discuss about smart fusion bomb, how to adjust the dose, what the drug concentration should be, including during administration. You need also to discuss about pharmacy standardized preparation of medication. And on top of that, you have to do, as we are, take it as a rule of thumb, assessment of self-assessment medication safety. Self-assessment medication safety, I will discuss it in a minute. They have a lot of guidelines. You can get it, you can adapt it accordingly. And also, as outcome of medication safety, the reporting system and analysis and the surveillance, you have to set up guideline. If you have a mistake in the medication error and the antibiotic, you have a set a guideline of antibiotic. If you have a lot of error, I think one of our experiences, we face it in our institution. We found a lot of error on anticoagulation and pain management and narcotic medication. At that time, we set up a guideline to prevent any medication error made to the patient. And you can put small message and some advices like medication safety alert from ISMB, from an institution. You can do it as a locally and send it on monthly basis, weekly basis to all your staff to prevent any medication error. As education tool, you can use it. Now, after a lot of things, and once you document, and once you establish the program, one of the things you can do it a self-assessment of medication safety. This is the, as I told you, self-assessment from ISMB. They have for community ambulatory care pharmacy, they have for oncology, for hospital, antithrombotic agent, high alert medication, preoperative. You can do set. This is the baseline of your data. Once you start any medication safety program or medication error, to see do you have any preventive measures or any preventive tools or any standardized thing to prevent medication error or not? What is your level? And at that time, this is I'll give you some explanation about the assessment. The assessment, they discuss about 10 elements: patient safety, drug information, patient information, drug information, communication of drug order, drug labeling, packaging, and nomenclature, standardization, storage, distribution, devices of medication, environmental factor or workflow and staffing, competency in staff education and the medication safety, patient education, and quality process and risk management. They discuss it in detail. We make a survey for community pharmacy. We have, I think it's 4-month pilot study. We including almost 13 primary care center and 23 community pharmacy as a pilot study at that time. And you can see the percentage, the level of the score. They find it as a percentage, like the highest percentage. We found it in the primary care center. Medication devices acquisition and user monitoring got very high score, reached to the 72%, while drug formation availability in the primary care centers was the lower percentage. If you compare it with the state and the USA 2000 score, 2001 or 17, because we have also study, you can compare it and see. Now you have a baseline for all medication safety for assessment for your institution. You can start, and you can monitor your patient, or make a self-assessment accordingly. You can do it annually. You can do it after 2 years to see how much your improvement of medication safety culture and medication safety measurement and preventive for all medication safety errors may occur to your patient. Then this is for community pharmacy. The same thing. We found the environmental factor and workflow staffing was the highest percentage, and the drug formation still was the worst percentage. Overall, community pharmacy beaten the primary care center at that time, and also this is the baseline. Now you can start with your medication safety and distribute and collect the data. And this is the baseline you can start with, and you can check all the assessment periodically. And also we have done it during Hajj period with the same thing. We found patient information was lowest percentage because, you know, the Hajj people, most of them, we're receiving annually million pilgrims coming to the Mecca. The problem with this one, you cannot determine all the patient information in million within 5-10 days. It's impossible. This is something incredible, and due to that, this is one of that you can miss it very easy as a low percentage. If you compare it with the environmental factor and workflow staffing, it was very high. The staff education, they get very high percentage because we have very comprehensive program for education for all the pilgrims and the healthcare facilities with a different language, Arabic and others. Maybe it's reached to the more than 50 language for the different language as patient education for all healthcare facility, including patient counseling. This is the percentage as impact of what's happening at that time. That I can give you the baseline. And from our experiences, we are learning from the medication safety program. We make KSA self-assessment of pain management medication safety. Dr. Iman was one of our member at that time from a group, and we tried to make it as a symbol of ISMB to be special for KSA, Kingdom Saudi Arabia. This is the list. We make it as like 10 key elements, the same thing, and we try to make it very simple with the very simple language, and for all staff you can also determine if you want to establish medication safety for pain management, you can start with to prevent any medication error in the future. One of the things you can get it from medication error, you can get annual survey or surveillance of medication error. This is one of the documentation system as outcome of medication safety medication error reporting system. This is for inpatient medication error and pharmacist intervention to prevent any medication error. This is mostly 9 months with almost consists more than 800 patients, and the total prevented medication was more than 3,000, and we prevented almost 3.8 error per each prescription, and we found the patient-related error reached to the 50%, and prescriber-related error was almost 45%, because at that time most of the prescribing was manually. We didn't use at that time electronic system yet. And also you can utilize, this is the after analysis. Once you analyze all the data, you can get from a lot of information as very organized information, like you can find which type of errors stages, like prescribing preparation. Now you have a problem with the prescribing error. Now, as outcome of analysis, you need to focus to the prescribing error. Let's go to the which type of medication errors. It's related to the patient related as prescription, or prescriber related, or dosage or drug related. What's the or therapeutic related? You can segregate your analysis and reporting, and you can based on that you can now see what's your weakness point and strength point, and where is your weakness points, and emphasize on it, set up guidelines, set up some preventive measures after do all the surveillance. Like outcome of medication error, we found majority of them, alhamdulillah, reach the near miss, which is there is error occurred, and but not reach to the patient, not harm to the patient. Okay, and we have some sentinel event. We don't have any sentinel event, and etc. You can segregate or know, identify, and determine which type of medication packaging. This is the, once you collect the data, you come up with a very organized analysis. You can determine where is your weakness point and strength point, and determine some, identify some solution to prevent any medication error in the future. And also, what is the causes of medication error? Causes and reason of medication error. It's a clinical information missing that you need. That means your staff need education, and also miscommunication of drug order. You need to set up communication, set up some community to discuss what is the problem with the pharmacist and physician and the nurse to prevent to solve this problem, because most of error came from clinical information, or maybe there is no drug information resources, maybe there is no electronic system of the resources. You need to prepare it to bring it to them to prevent the medication error. Now, what's the top 20 medication involved in the medication error? We found the paracetamol oral or IV. It was the high percentage. A hand number, Nexaparin. And now you need to set up, do we have a problem with the dispensing or prescribing of this medication, and set up and discuss in the committee and identify what's the solution we can set up and put it down in the practice to prevent any medication error from those medications. And also, as a learning outcome of the medication safety program and medication error, we set up some, because we found a lot of mistake of emergency medications, and we started to standardize the concentration of the medication error. We discussed about the drug administration, and we found a lot of error in emergency medication. We started to standardize to prevent medication error. Some hospital we don't have IV admixture or standardized IV admixture, and the nurse should prepare all the medication, and instead of the nurse will ask you which medication, what's the concentration, what's the maximum, what's rate infusion, shall we give a peripheral line or central line, what's the rate, the maximum rate. We solve this problem. We set up a form and tell the patient, if you want any medication, just fill it and sign it, and let the nurse to prepare according all the type of compound of this medication. They can prepare it upstairs if you don't have any IV admixture. Also, if you have, even if you have IV admixture, the pharmacy should follow the guideline to prevent, especially in the emergency medication. They use an ICU, they did an emergency section, and we found a lot of error in those areas. Also, it's also documented in the literature. This is a list of emergency medication. This is for adult and this is for neonates. Also in the neonates, they found a lot of error for emergency medications. We specify the concentration and shall we give type of administration, peripheral line or central line, what's the concentration rate and maximum rate. And also we standardize a lot of in the guideline for electrolyte replacement, how much you give the patient. This is the list. We set up like potassium chloride because a lot of error it was found at that time. We make it as manually, then we can convert it to the electronic system as electronic prescription. We put them just specific concentration. We listed all the concentration and we put it in the list and let the physician just to choose which type of concentration do you want and how much. If you want to give what the sound 20 milliequivalent to 100 cc, this should be given central line. You have to choose among the list, and the nurse is follow the instruction. And instead of tell the nurse, just preparing like this way, shall we give central line or peripheral line? Maybe the patient get dangerous and the emergency. It's a lot that dilemma may occur during an emergency in ICU or even general ward. To prevent all this problem, it's electronic. You can choose it. It will solve a lot of problem. We didn't document the impact, but I'm asking the people, what's the impact of the satisfaction of the nurse and the physician? They told me the physician, especially the nurse, they are very high satisfied once we establish this system to prevent any medication error. And that one it was an adult, and this is now also standardized for pediatric and neonate. Also for medication, you know, SHB, American Society of Health System Pharmacists, they are discussed about standardized for safety initiative. And instead, we want to prepare the medication. You need to specify which drug concentration to prevent any medication error, because the standard concentration is very, very high range. You can start with such and such milligram per ml up to. This is during preparation. A lot of confusion, a lot of error occurs, and we try to standardize. We standardize the concentration, and also SHB, they standardize also the concentration. Locally, we stand both. We standardize the concentration and we standardize the volume. Like if you want to dispense a medication like acyclovir and mecacin, for example, the only solution that we have, we can dissolve it 500 and 100 cc. You can dissolve it more than that, but we are not allowed to dissolve more than that. This is the fixed concentration and fixed even volume. And also we discussed about azithromycin. We give you maybe 1 to 2 volumes. Some of them we put 1 volume, some of them 2 volume accordingly. We will not put it more than that. If you want, you can double the dose or decrease the dose. For pediatric, the same thing. We have a different volume. We have a 25, we have 5 cc, 50. We give you some specific concentration. We design it according to the general dosing and standardized concentration, fixed concentration, and also fixed volume. This can prevent a lot of mistake during preparation. Even if you have IV admixture, even though if you don't have it upstairs, if the nurse preparing medication, she needs something very easy to utilize it and friendly use. If you give him a guide, give her a guideline for this one, it will prepare it very easy, and you can make the life very easy for her to prepare and give it to the patient. And also a learning system as outcome of medication errors is economic burden. You can calculate how much cost efficiency or how much cost avoidance if you apply or implement medication error. This is the same study, we have done it, and that one was give you exploring of the analysis of general medication errors. This is we calculate what's the cost impact, because this is very important to higher administration of the hospital. Tell them how much the pharmacist can prevent and how much you can convert it as a cost avoidance. And that hospital, with the same study, we estimated the cost avoidance with the 9 month almost reach to the 98,000 US dollar within 9 months. Another study also for pediatric hospital in Obigani with a 1 year with 800 patients with a 2,000, more than 2,000 preventive medication error. We estimated the cost avoidance with almost 116,000 US dollar annually. This is the data of medication error that can give you now some information about economic burden if it's okay. If there is no prevention of medication error, this is economic burden sequences may occur to your patient and to your system. Also, another thing with the learning system of the medication error, you can design new program. The main problem that we found during Ramadan, all of them, they break a fast, and all of them, they wish to tell you, I want to fast. Even in the hospital, believe me, my experience is even you tell the patient, please break your fast and take your medication at a specific time, they will not listen to you. They will not listen to you. Even in geriatric patient, try to make very easy life to the patient and try to discuss with the physician to change the frequency, and instead of give him 3 times a day and 4 times a day and break your fast, no, change it to the alternative medication and give it once or twice a day. This is your patient can very satisfied and can cooperative. And if you insist to the patient and push the patient to break fast, believe me, he will not listen to you. My experience at the hospital, we have facing a lot of problem before designing and switching program, we call it Ramadan pharmaceutical care. This is standardized. We put a standardized system. When the Ramadan is coming, please try to switch the patient as much as you can, once or twice daily, to prevent any break fasting. This is okay with ambulatory care system or emergency or even inside the hospital. Try to make it as a system. This is as a learning what we found it in the lot of error, because sometimes physician prescribe medication which should be given 3 times a day over 8 hours. They give it during even period, and even before hours they give the patient as a wrong dose and wrong frequency. Also, the same thing, be careful. You need to identify, because the health insurance now, they're covering the medication errors. And you need to, this is just recent study where we try to implement health insurance done by pharmacists and which medication they are concerned about as health insurance pharmacists. And we found high-risk medication and home care medication most practiced by pharmacists, and they are willing to practice average perception to practice health insurance and to prevent all medication errors. It's almost reached to the 3.29. Be careful, because high risk medication is high prone to get mistakes, and also for home health communication, high percentage of discrepancy at home care. A lot of reported they are showing a lot of medication, a lot of errors in the home health care facilities. Be careful. This is very important. This is what we founded once we established as outcome of learning system of medication error reporting and medication safety. I think it's very important to report medication errors, including as among of medication safety. It's very, very important. You need to report it. You need to make it very easy. Make all the program very easy. I think it's very essential to establish everything is manually. It's not necessary to be computerized and need what's called computer system unless you applying the medication error reporting. No, you can apply it manually, but you needed some channel of reporting, organizing system, and to get all these data and collection of the data, analyze it, reporting, education, and the circle it's coming to prevent all medications. I think this is the brief what can give you something about medication error events reporting and learning system as the outcome of medication error and medication safety program. Thank you very much for your listening. If you have any question, I'm pleasure to answer you.
Thank you, Dr. Al-Aoumi, for your wonderful presentation. Now we will answer some question. Our first question: how to follow up improvement of medication error?
Okay, it's very important to follow up your system. You need, once you establish and see your baseline, the first report of analysis of medication error, you can find a lot of incidents and a lot of errors as a category of D, E, or what we call a sentinel event. Some people admitted to the hospital, some people they died. This is can give you high alert of the medications error, and be careful. Next year or next after quarterly or periodically, you need to now push all the sentinel event to be near miss or high risk. If you find that if you find like this way, that means your medication safety culture is improving, and there is no sentinel event, and there is no any patient admitted to the hospital, you can avoid of cost. And also you need to calculate how much you cost avoidance annually and how much you increasing or decreasing accordingly. This is can give you a picture how you're improving. I remember before a couple of years, we once we established medication safety program in 2012, that a number of cases it was sentinel events almost reached to the 15 sentinel events at the death cases. After that, after 1 year, decreasing to the almostly I can say 12 or 10. Then after that, third year, reached to the 7, 8. Last 2 years, it was 0. And most of error switch from sentinel event to the near miss or high risk of the error prone. This is you can follow up. And also the documentation system of economic burden. You calculate how much you cost avoidance, that you can monitoring your system and tracking your system, that your system medication error it's improving and it's improving and prevent in high cost avoidance. And also you can find the changing of the analysis or outcome of analysis. Let us say I'm assuming this year most of the error came from antibiotic. I'm establishing guideline. Once I'm establishing guideline, it's supposed that medication error of high risk medication or any medication, pain management medication should be less. Next year, once you analyze it, you will not find you supposed not find the pain management medication as a part of sentinel events, as a part of causing error. You can find another medication. This is you can improve your system and follow up. It's a continuously dynamic improvement in your situation for medication error and medication safety.
Thank you, Doctor. Our next question: how we can start a medication error reporting system?
Okay, the simple start. Try very simple and make it very simple thing. Start with a manual thing. Doesn't need to computerize. Establish committee, design a form, and you can start with just one form or two form, medication error or adverse reaction form, and you need to make a very simple education program collected in one lecture. You can distribute it and educate and make every month or every quarterly education to your institution, and then document and encourage your people to document for the pharmacy staff, and also for physician. In the practice, we found the most people they are document of medication error. They were pharmacists or nurse. Physician is very rarely document medication error, even rarely document of adverse reaction. Try to emphasize to your staff as a pharmacy staff to document all the medication error. Once you analyze your data, present it to your people, present it to your healthcare staff, and tell them this is the impact, and this is what should be done, and this is should be educate, and etc. By this way, you can start very simple and expand. You can expand your services frequently and easy with the friendly use program, because sometimes some people for medication error, once you document, you can find a lot of opposite, and the people they will stop against you, because once you document, you report it. Don't put any name. Don't put any name, please. We are here just to improve the system. We are not blaming everybody. No, just remove the name of the patient. Should not put in any reporting system. Just discuss the system, how to avoid, how to improve, how to prevent medication errors.
Thank you, Doctor. Our last question, how frequently can we do the self-assessment of medication safety program?
The self-assessment, it depends your situation. If you have a lower score, and once you have a lower score, you put some action plan, and my personal experience is, at least you need annually. If you have very low score system, if you compare it with our literature or local or United States literature, I think if you have a lower score, you have make it at least annually, because the self-assessment of medication safety is very huge and very 10K elements, a lot of things. You need the time, you need the team to evaluate and assess your situation. I think it's maybe annually of the 2 years you can follow up your system, unless it is very low score, and you implicated with very high risk medication and a lot of sentinel events occur. I think every 6 months you can do it. Until you stop it, then you can make it less frequently, every 2 years or 3 years. And also you can segregate the assessment from just make the first one generalized self-assessment of medication safety. Once you found there is something or high mistake or low score for the high risk, do another assessment for high risk medication. If you have pain management, do assessment for pain management. Another assessment to detail where is the reason, where is the mistake, and where is the tool should be prevented or established to prevent any medication error or the complication of medication error. This is very important. Try to make it very simple, then expand thoroughly.
Thank you, Doctor. We have one last question from one of the participants. Does the MOH protect the medical staff and health sector against lawsuits due to medical error in general?
Yes, because the new system now to cover by once you establish your system, once you establish all the preventive measure, once you report, I think the reporting there is a recommendation, and the committee they give some solution, like I need such and such, you need to build something, you need to improve the system, and the Ministry of Health very supportive for that one. And also another new system now is coming for health insurance coverage. Health insurance coverage is very important to cover if there is any mistake. The human, sometimes there is a human errors or impact or the reason of the medication error. And for any reason, maybe the pharmacist get errors, and who's covering? Maybe the patient has a complication or something. I think health insurance can cover very well of this area, inshallah.
Thank you, Doctor. I think we reached to the end of our presentation today. On behalf of the Saudi Patient Safety Center, I would like to thank Dr. Yusuf Al-Omi and the audience for their active participation. And as a part of the Saudi Patient Safety Center effort to provide you with timely topic and interesting speaker, we'd appreciate if you would fill out the evaluation survey that will be sent to your email after the session. Thank you for joining us today, and we look forward to welcome you back in future webinars.